We are live, please.
Good evening and a very warm welcome to iFocus Online. This is lecture number 588 and we are on our back to the basic segment with class 16th of Ophthalmic Anatomy. Today's class is on anatomy of the cranial nerves relevant to ophthalmology by Dr. Rashmin Gandhi, sir from Center for Sight, Hyderabad. A few words on our esteemed speaker. He did his MBBS from Pramukh Swami Medical College, Karamsad, Gujarat, followed by DNB from Shankara Nethralaya Medical Research Foundation, Chennai, followed by double FRCS from Edinburgh and Glasgow. He did his fellowship in neuro-ophthalmology from Wilmer Eye Institute, Johns Hopkins Hospital, Baltimore, USA. Currently, he is the director at Cygnus LLC, United Arab Emirates, and director at Axon MedTech Private Limited, managing director at Foresight Worldwide, consultant and director of neuro-ophthalmology services at Center for Sight, Hyderabad, adjunct professor at the University of Hyderabad, founding member of the Indian Neuro-Ophthalmology Society, fellowship director and board member of World Headache Society, country director at Davos Alzheimer's Collaborative of the World Economic Forum Initiative. Among his vast experience, he has also been the senior ophthalmologist at director and board member at Shankara Nethralaya Chennai and adjunct professor at IIT Madras. He has many awards to his name. To name a few, he's got the Achievement Award from APAO Society, Special Gold Medal by Intraocular Implant and Refractive Society of India, Award for Academic Excellence by the then Honorable Chief Minister of Gujarat and now Prime Minister Shri Narendra Modi ji, C.V. Ananthayanam Memorial Award from His Excellency Shri Rosaya, the Governor of Tamil Nadu, Young Super Achiever of Chennai Award, and Best Associate Consultant of Shankara Nethralaya. He has authored and co-authored several books and scientific papers in neuro-ophthalmology, and he's an invited speaker across the world with several coveted research projects and publications, and has delivered keynote addresses, faculty lectures, and conducted hands-on workshops at major global conferences. Thank you so much for being with us today, sir. It's an honor and privilege to learn from you, and over to you.
Thank you so much, Mahima, for that very kind introduction. It's always a pleasure. iFocus, when we started in 2015, it has grown by leaps and bounds, both offline and online, and we're very proud and happy to have such vast library of lectures which is available. And I'm told that wherever we go across the globe, our knowledge is accessed, and I think that's a testament of the quality of lectures that we have, and also the really hard work that is put on behind the scenes by Megha, Rolika, Nritika, now Mahima, and Anupama. So with those words, let's dive into a little dry topic, which is anatomy. I'm trying to sort of make it in a way where every point in anatomy that we need to remember, I'm just trying to get the clinical applied aspect of that point so that we remember, and second, also the importance of those points in anatomy. I'll try to cover as many cranial nerves that I can. My focus today is going to be mainly on the second nerve and the sixth nerve. And then around the course of the sixth nerve, I'll also cover third, fourth, and the fifth nerve. So let me start right from the beginning. And here I would put our panelist on the spot, because since this is a clinical picture, this is a picture of somebody who had a history of injury on the head. And then he lost vision in the right eye. And he was told that he has a traumatic optic neuropathy in the right eye. Obviously, I put this photograph here because I wanted to emphasize a point in anatomy of how the optic nerve is formed from the retinal fibers. So if any of you, if you are able to tell me what you see in the right eye and the left eye, I'll be happy. What do you think is happening in the right eye?
There is pallor of the disc.
Absolutely, you're right, Anupama. There is a clear optic atrophy of the right side, and that was attributed by the previous treating team as a traumatic optic neuropathy. Now, I'll be very happy, and I know it's not very easy, but looking at the left eye, are you able to see anything in the left eye?
There's a wedge defect. Is that the wedge defect?
Exactly. Amazing. Very nice, Dr. Banka. You're right. That if you look at the left optic nerve carefully, what you'll find is that the superior pole here and the inferior pole, they are pink. Both the poles are pink, while there is a clear pallor here in the temporal side and also here in the nasal side. So that is also known as a wedge defect or a bow tie optic atrophy or a band-shaped optic atrophy. So let's begin the anatomical basis for this particular problem, a bow tie optic atrophy or a band-shaped optic atrophy. Now, again, if you know it, great. If you don't know, it's fine. Would you know why would you get this particular kind of optic atrophy, which is just the bow tie or a band-shaped? All right, so let me give you the anatomical, and that's why we are here. We want to find out the anatomical basis of the disease rather than really discuss the course of the optic nerve, which is already given, and one has to only remember because there's really nothing that we can teach there. But let's see if we are able to find out about the anatomical basis of some of these disease processes. So what we are discussing here is why there is a bow tie optic atrophy. And the answer lies in anatomy as to how fibers get attached to the optic nerve, how the retinal fibers, because the optic nerve is actually formed by the convergence, confluence of the retinal nerve fiber layer, which goes and forms the optic nerve. So how these fibers get attached at the optic disc, the anatomy, the first step in anatomy, is the basis of bow tie optic atrophy. So as you see here, this is a diagrammatic representation where you have a nasal side here and a temporal side here. Here we have marked macula. So this, the black bundle, what would that be called?
Papillomacular bundle.
Exactly. So this is a papillomacular bundle. So as it's seen clearly here, it gets attached to on the temporal side of the optic disc on the horizontal raphe. All right. However, the fibers which are temporal to papillomacular bundle, they actually go and get attached to the superior and inferior pole, and these are arcuate fibers. All right. So papillomacular bundle occupies the horizontal aspect, while the arcuate fibers from here would get attached to the superior and inferior part of the pole. So papillomacular bundle will go here. The nasal fibers would get attached like this as well to on the inferior on the horizontal part of the nasal part of the optic disc. So in other words, fibers nasal to macula occupy the horizontal aspect of the optic disc. Fibers temporal to the macula go to the superior and inferior pole, and these are arcuate fibers. So which particular disease process would predominantly affect the arcuate fibers, which would then lead to the superior and inferior? The pathology then is mainly exhibited in the superior and inferior pole of the optic disc. That will be glaucoma. Glaucoma predominantly, or glaucoma process starts by effect predominantly in most glaucomas. The process starts because these fibers, these arcuate fibers, are affected, which are actually attached to the superior and inferior pole of the optic disc. And that's the reason why in most of these chronic glaucomas, the first sign would be vertical elongation of the cup, because the disease process is predominantly attacking the superior and inferior part. And then there is the thinning of one of these, either superior or mainly the inferior rim, and then the notch. And that's how the progression of the glaucoma occurs. So the arcuate fibers get affected in glaucoma, but here what we had in this patient is the nasal fibers nasal to macula, which are affected, while the arcuate fibers seem to be all right because the superior and inferior pole of the optic discs are fine. So two questions. One, if predominant nasal fibers are affected, what kind of visual field effect would you expect? If there is a nasal problem, it will get translated into what kind of visual field effect? Where would you have a
Temporal field effect.
temporal visual field defect? Absolutely right. Patient would have a temporal visual field defect. That's what this patient had. And we are going to talk about this little more in the coming cases. So that was the first point I wanted to make. Optic nerve, the anatomy, the optic disc, the nasal fibers nasal to macula are mainly attached in the temporal half, while the fibers temporal to macula, they are attached in the superior and inferior part of the optic disc. All right, then let's make sure that we have some theory here where arrangement, as I said, ganglion cell exons, RNFL, which are mainly arcuate fibers, papillomacular bundle, which are responsible for central vision, and they're also responsible for color vision, right? So papillomacular bundle, because they convey the impulses from the macula to the optic disc, they have one of the highest rates of metabolism in the body, the papillomacular bundle, because effectively most of the central vision is being conveyed to the optic disc from the macula. Also the color vision, because cones cones make up macula and fovea. So color vision and central vision. So now imagine any disease process which is slowing the metabolism down in the body would have an initial impact on this papillomacular bundle because they require a lot of energy. And that's the reason why if somebody has a nutritional optic neuropathy, somebody has a vitamin B12 deficiency, these are the fibers that are likely to be affected first. Somebody having a hereditary optic neuropathy like LHON, Leber's hereditary optic neuropathy. Leber's hereditary optic neuropathy, do you know how it's transmitted?
Mitochondrial inheritance.
Exactly, it has a mitochondrial inheritance. Now we know that mitochondria is the powerhouse of the cell. And so the cells which are highly active is where mitochondria is very active. So again, LHON, nutritional optic neuropathy, they all have a predominant or an early impact on the papillomacular bundle. That's the reason why nutritional optic neuropathy and LHON would have central scotoma from the fixation to the optic disc. So that's the reason why, because these pathologies affect the highly active papillomacular bundle, which is a connection between macula and the optic nerve. We spoke about arcuate fibers getting affected in glaucoma and horizontal orphan. There is no. So one more point here. Ganglion cell of axons are non-myelinated. The myelin actually stops. The myelination optic nerve is actually a white matter tract. It is a part of a white matter tract of the brain. So that means it has a myelin. However, myelination stops just behind the eyeball. So that's the reason why you don't see a myelin normally on the retina. However, in few cases, you can have a myelinated nerve fiber, which is basically a congenital defect. In most instances, myelinated nerve fiber does not really interfere with the vision. However, only clinical significance of a myelinated nerve fiber is that if that patient, somebody had a myelinated nerve fiber, and then if they lose that myelinated nerve fiber, possibility is that they are suffering from demyelinating disease. Like multiple sclerosis. We spoke about disc topography, that in the disc, otherwise inferior, superior, temporal macula, they follow the exactly same rule. And we spoke about these visual field defect. Now, let's dwell more into a cellular anatomy of the optic nerve, because that also has an implication on the disease process. As I mentioned, optic nerve is just an extension of central nervous system where the myelination is done by oligodendrocytes. Now, does it ring a bell? The myelination being done by oligodendrocytes, are you able to connect any optic neuritis which attacks the central nervous system, but also the optic nerve because of the presence of oligodendrocytes? You have optic neuritis, which is caused by disease like multiple sclerosis, demyelination, but there are other causes of optic neuritis. So any antibodies which come to your mind, which affects predominantly optic nerve because the oligodendrocytes are present there. So there is an optic neuritis where the incidence I don't know whether it's a coincidence, but the incidence of this particular optic neuritis has increased after the outbreak of COVID-19, and that's called MOG-related optic neuritis, right? And MOG is, what is the full form of MOG? MOG is myelin oligodendrocyte glycoprotein, and they are highly antigenic. And they are present on the surface of the oligodendrocytes. So antibodies against this can lead to inflammation of the optic nerve and patient presenting to you with optic neuritis. So it's easy to remember now that the myelination of the optic nerve is by oligodendrocytes, and always remember MOG. It contains glial processes, which stabilizes the architecture of the optic nerve, of the neurons. They are all cementing and stabilizing structures. Now, what is the importance of glial processes? These glial processes can have a particular water channel called aquaporin 4. Does that ring bell? Another area where antibodies can attack and lead to optic neuritis. So first we said MOG, myelin oligodendrocyte glycoprotein. Now we're saying there is something on the glial processes, that is aquaporin 4 water channels, which are responsible for one more form of optic neuritis. So antibodies against these water channels cause what is known as neuromyelitis optica, or Devick's disease. So the optic neuritis related to NMO is because of this aquaporin 4 antibodies, and these are present because of the presence of glial processes on the surface of the optic nerve. So that's about, now this is intuitive that it's covered by meninges and it has subarachnoid space. What is the importance of these 2 points? That optic nerve is covered by meninges, and it is, because it's covered by all 3 meninges, it also has the subarachnoid space. So conversely, the cerebrospinal fluid surrounds the optic nerve. So what is the importance of this anatomical feature?
Papillary edema.
Exactly. Very good, Dr. Amatya. Because the cerebrospinal fluid is surrounding the optic nerve, if the pressure in the brain, when the CSF is circulating, the pressure goes up there, that pressure gets transmitted also on the optic nerve. And that's the reason why raised ICP, one of the most prominent feature of the raised intracranial pressure, is papillary edema. The disc swells up because the CSF surrounds the optic nerve. And then we know that the segments of the optic nerve, it starts from the optic disc in the eye, traverses the orbit, then goes through the optic canal into the cranial cavity, and then there's an intracranial course of the optic nerve before it merges into the optic chiasm. And as we said, the clinical relevance is varied by the segment that we are looking at. Now let's look at the segment-wise clinical correlation. We mentioned that intraocular optic disc, because of the pressure, and this is the choke point, where patient would have a disc edema when the intraocular pressure rises. Intraorbital, any orbital disease process, which can be tumor, it can be inflammatory disease of the optic nerve, like IgG4 disease, or thyroid, dysthyroid optic neuropathy because of the thyroid eye disease. These are all, so any orbital process would have an impact on the optic nerve function because of the intraorbital course. The intracanalicular course, the optic canal, it is quite a vulnerable area of the optic nerve. Please remember, the optic canal is quite small, and then optic nerve traverses to the optic canal. So even a minor inflammation of the optic nerve may be related to the blunt trauma, would lead to compression of the optic nerve by the optic canal, leading to compressive or a traumatic optic neuropathy. The fracture of the optic canal also can compress on the optic nerve, leading to traumatic optic neuropathy. So that's about the optic disc and the optic canal. Let's look at some of the other anatomical features of the optic nerve. Now, to correlate that, let me show you this patient. 46-year-old female, sudden painless loss of vision. Patient woke up with reduced vision in the morning. Affected eye visual acuity was 624. Patient also is a known case of systemic hypertension, and she's on antihypertensive medications twice a day. And this is how her optic nerves look like. Let me tell you that though the right optic nerve may appear pale, but let's ignore it right now because as a photographic artifact. And you see here that there is a optic disc swelling with a little hemorrhage on the surface of the optic disc. So let me show you the history once again. A 46-year-old female patient woke up with a painless loss of vision in the morning. Hypertension on antihypertensives in the morning and in the night. And this is how the optic nerve looks. What thought process or what are the differentials that you're thinking of right now?
Is there a associated headache?
Sorry, I couldn't hear you.
Is there any associated headache?
Associated headache.
Hello?
No.
Associated with headache? No, the patient did not have painless loss of vision.
Transient ischemic attack.
There was no transient ischemic attack, but what are you thinking of? What do you think this patient might be having? This is since
Raised ICP.
Raised ICP is a good thought. However,
Bilateral.
it would be bilateral. Now, and raised ICP very rarely, very, very rarely would have an acute loss of vision. While what the patient with an acute loss of vision, and what you the emphasis of the diagnosis is that patient woke up with loss of vision in the morning, and that patient was on antihypertensive medications in the morning and in the night.
Nocturnal hypotension of the disc causing splinter hemorrhage. So
what kind of neuropathy is that? You're right. The mechanism is right. The patient had a nocturnal hypotension causing non-arthritic anterior ischemic optic neuropathy. So basically, ischemic optic neuropathy. However, this is not a clinical discussion, so we need to now correlate this to the anatomy. And what I want to correlate here is this part. That patient woke up with a loss of vision. Why would that happen, and what are the anatomical bases of this? So here we need to know about the blood supply to the retina, to the choroid, and to the surface of the optic disc, and a particular characteristic of a blood supply. So would you know what's the difference between a blood supply to the retina and to the blood supply to the choroid? Any differences that come to your mind? If you do, yes, Mahima. Do fundus fluorescein angiography, you inject the dye, you will see a particular characteristic which is rooted in anatomy, anatomical difference in the blood supply between choroid and retina. You'll find something.
First we see the choroidal flush from the choriocapillaries.
Exactly. What is choroidal flush? Excellent answer, Dr. Kaushal. What is the choroidal flush?
The leakage from the choriocapillaries.
Exactly. What it tells you is that choriocapillaries, even if they are healthy, would leak the dye. So choroidal flush is a normal feature of fundus fluorescein angiography. So in other words, choriocapillaries are fenestrated and they don't form a part of what is known as blood retinal barrier. While the retina, you will find the leakage only if there is a problem. So if patient has diabetes, the patient has diabetic retinopathy, patient has a microangiopathy, is where you will find the leakage. So the retinal circulation forms a part of blood retinal barrier. That means the capillaries have a very tight junction, not allowing normally the dye to leak out. The same would apply to the circulation to the optic disc. So point number one, circulation to the optic disc is part of blood retinal barrier. So normally you don't find the dye oozing out from the retinal circulation. The second part, both retinal circulation and the optic disc circulation has what is known as autoregulation. Now, autoregulation is a physiological feature which is also present in a lot of capillaries supplying blood to the brain. Autoregulation implies that the blood flow to the target organ or a target tissue is managed by a local metabolic need. So if there is increased carbon dioxide, there would be vasodilatation to flush the carbon dioxide away. If there's an increased oxygen, then there'll be vasoconstriction because you don't require more oxygen to the tissue. All right, so this is autoregulation. So the blood flow to the tissue is regulated by the local metabolic need. That is autoregulation. Autoregulation is present on the circulation of the optic disc. Well, since we're talking about anatomy, let's look at an example of these two. Let's say in the retina, where would you exploit this, or where would you see that increased oxygen would lead to vasoconstriction? Give me a disease example where a probable hypothesis of that disease is based with this vasoconstriction because of increased oxygen. And in the olden days, where would you have used this hypothesis that if you increase a local carbon dioxide, there'll be vasodilatation? These are examples of autoregulation. Which disease process is linked with oxygen? Probable. So that's ROP. You know, we always ask in a baby whether patient was given
Oxygen supplementation.
Why? Because if the oxygen concentration increased, now a patient already has an immature retina, the blood supply is not really formed. On top of it, the oxygen has increased, leading to further vasoconstriction, leading to occlusive disease. ROP is an occlusive disease, vaso-occlusive disease. So you have precipitated vaso-occlusive disease. It was believed, based on this anatomical and physiological feature, that you precipitated vaso-occlusive disease because you give more oxygen. But whether that's true or not, at least it helps us to remember this, that autoregulation means increase or decrease to blood flow to a target tissue. What about the other way around? Where would you have carbon dioxide increase and vasodilatation? This is, would not have come across this, but this used to be a treatment modality for a particular disease in olden times. You will ask the patient to breathe in a plastic.
CRAO.
Exactly. One of the treatment modalities which used to be deployed for CRO is you ask the patient to breathe in a plastic bag, hoping that there will be increased carbon dioxide in the retina, leading to vasodilatation, so that if there is an embolus which is blocking at the central retinal artery, it will get dislodged, the circulation will be restored, and hopefully patient will be okay. So whether that worked or didn't work, at least it gave us an idea to remember this autoregulation. And same applies to optic nerve head. Optic nerve head also has an optic autoregulation. So we come back to our patient and say why patients with anterior ischemic optic neuropathy generally wake up in the morning with reduced vision. And that's because it is believed that these patients already have vasculopathic risk factors like blood pressure, diabetes, hypercholesterolemia. Now, as you very rightly mentioned, that if these patients, for some reason, develop nocturnal hypotension, so if there is a nocturnal hypotension in a normal patient or a patient with an intact autoregulation, this would be compensated by reactive vasodilatation and managing the pressure locally at the optic nerve head. However, if these patients have already a reduced autoregulation, when there is a nocturnal hypotension, there is no reactive vasodilatation, there is no compensatory blood flow to the optic nerve. So that hypotension affects the blood flow to the optic nerve, which can be transient. Which comes to another important anatomical feature that you will find, which is a basis of AION in these patients. What do you see in a normal, the other eye optic disc? In patients who have non-arthritic AION, what do you expect to see in the other optic disc? Have you heard of disc at risk, or a crowded disc, or a small disc, small cup?
Pseudopapilledema.
Hyperemia.
Yes, exactly. So these patients already have a small disc and a small cup to begin with. And again, an anatomical correlate of why some patients develop non-arteritic AION because they already have a small disc with a small cup. The disc is already crowded. On top of it, hypotension was not compensated because of failure of autoregulation. So because of hypotension, there was, in a nocturnal hypotension especially, the disc got swollen a little bit because it was not compensated for. And already a small disc gets further swelling, it compresses on the surrounding optic nerve, leading to patient waking up with attitudinal visual field defect or reduced vision because throughout the night, this cycle continued. Already a small disc became even smaller, already a compressed fiber became even more compressed, leading to AION. So in short, what we discussed was the optic nerve has oligodendrocyte, has glial processes. These two are important for us to know because NMO and MOG are caused attack optic nerve and optic disc because of these anatomical features. AION, which is the other important optic neuropathy, the anatomical features are disc at risk, small disc in a small cup, and failure of autoregulation. Again, the disease pathology being the causative pathology being in the optic nerve head itself. Now, one more important anatomical feature. This is what do you see here?
It is
Edema.
Sorry?
She said disc edema, sir.
Yes, this kid. And what do you see here in the field?
Inferior field defect.
Inferior field defect, and which is respecting a horizontal midline. So this is
The
called,
horizontal median.
yeah, so this is called inferior altitudinal defect. Again, a feature of AION. All right. This kind of visual field defect, inferior altitudinal defect, is a feature of AION. So again, an anatomical reason, because let me show you a slide so you'll understand. Vascular supply and clinical relevance. Anterior optic nerve is supplied by SPCA, short posterior ciliary arteries. Optic arterial circle called circle of Zinholler also is involved. What is important for you to know is there are watershed zones. So the superior and inferior, as we saw on the arrangement of the nerve fiber, superior and inferior nerve fibers, they behave separately as an independent entity, and also that blood supply is independent. And that's the reason why, because the blood supply is independent, if there is a predominant inferior edema or predominant superior edema, as happened here, you'll have an inferior altitudinal defect which will respect a horizontal midline. It will respect a horizontal midline because this area is supplied, the capillary plexus for this area and this area are separate. The nerve fiber are separate. They separate out. These are attached here, these are attached. So again, an anatomical relevance of an altitudinal defect. All right, the last part in the optic nerve, I wanted to show you this. We partly spoke about this because I wanted to introduce one more anatomical important aspect of the optic nerve, how it merges in the optic chiasm. I know it's a little difficult, but would you be able to tell me? So this is the left eye and this is the right eye. Okay. What do you think is the right eye vision? How does it look like?
The left eye has a quadrant anopia, sir. The
Yes. Now, is it
a
nasal,
superior temporal quadrant anopia.
nasal or temporal? Very good. Excellent. So you have a blind spot here.
And
Blind spot is always temporal. Please remember this, blind spot is always temporal. Blind spot is because of the optic disc. Optic disc is nasal to macula in the retina, so it will project on the opposite side. So blind spot is always temporal. So this is a superotemporal defect. Okay, so you're right, it was a quadrantic defect, but mainly a superotemporal defect. And the right eye is the kind of defect you get when an optic nerve is severely damaged. So this is an example of a junctional scotoma. This is called junctional scotoma, where there is an optic nerve kind of defect on one side and a superotemporal defect of the opposite side. And the anatomical basis of this is what is also known as anterior knee of von Willebrand. So if you remember, the optic nerve, and especially the infranasal fibers, which serve the supratemporal quadrant, they make a small loop before joining the chiasm. And that's the reason why you have an opposite side. So if there is a lesion here, you have this optic nerve is completely gone, and a supratemporal visual field goes because the infranasal fiber here. So that's the basis of a junctional scotoma because of the knee of von Willebrand, which is often asked as a short note for you. So you say, what is knee of von Willebrand? It's a loop of inferior nasal fibers entering a contralateral optic nerve. It is debated, there has been some controversy. It is believed that von Willebrand observed this particular loop maybe because of the staining artifact, but the junctional scotoma is real. So maybe there is some kind of fiber arrangement which von Willebrand suggested does exist. And what is the clinical relevance? As we said, it is an anatomical basis of junctional scotoma of trachea. All right, so that's the entire gamut of applied anatomy of the optic nerve. Let's change gears and let's see what's going on here. Here's a young patient complaining of diplopia in the left gaze. Patient looking to the left. To the right. Looking up and looking down. All right. Would you like to see the video once again? Here. Looking to the left. See here. Looking to the left. See here. Looking to the left. And see here, something is going on here. Looking to the right. Would you like to venture, any of you, Anupama or Megha? What do you think is happening here?
The patient has left lateral rectus palsy.
Abduction limitation of the left side, excellent. Anything else?
And some limitation of other in other gazes as well in the left eye.
No, let's say that everything else was okay. This is a fairly good adduction. Elevation, depression, I didn't show you, but they were normal. Okay, so one is you did find abduction limitation of the left side. What did you find on the right side?
Sir, on the right gaze, there was some suckered in the.
Some nystagmus. There was some
Yeah,
nystagmus looking to the left. Exactly. And now what here? This is your specialty. What do you have here? See something jetting out.
Yeah.
Some surgery has been done. What do you think? Some implant has been given to him.
Or
Gold weight implant. Okay, when would you implant?
Okay.
When do you operate? When do you do gold weight implantation of the upper eyelid?
lack of
So for lag of thalmos in 7th cranial of palsies.
Exactly. So now what you have here is that somebody did attempt to correct leg ophthalmos because you can clearly see the gold weight here. So in other words, the patient has a 6th nerve palsy, as Anupama said, and also a 7th nerve because a gold weight implant has been given. And maybe I'll give you a little more idea about what's going on with the 7th nerve. You can find here that patient trying to look up. See, there is still a little bit of lag ophthalmos. I mean, it's well corrected, but you can see it's not, and you can see here. All right. So now, the anatomical basis, we are talking about abduction limitation. So 6th nerve, as you said, and a 7th nerve. Where would you localize the lesion? Well, that's the question. Okay. And also, don't forget what Megha said, that patient also had nystagmus. You can see here nystagmus of the right side when patient was trying to adduct that eye. Okay, so that's one picture. Now let's look at another picture and see what happens in this patient, and we'll compare and contrast the anatomical basis. So here is a patient Again, there is a gold weight implant on the right side. You can see clearly. Patient trying to look to the left, see what happens. And now he is looking to the right. He's trying to look to the right here. He's trying to look to the right in this frame and trying to look to the left and trying to look to the right. Now he's trying to look to the left here. Everything okay. Look to the right. No abduction here, no adduction here. Okay. So what's the difference? Here again, there is a gold weight implant. So this patient also had a seventh nerve. The difference between the two videos is that in the previous video, patient, the opposite eye was adducting but had a nystagmus. Here, this eye did not adduct at all. So in other words, patient had a gaze palsy. Right? Patient could not look to the right at all because the left eye was not, the right eye was not abducting and the left eye was not adducting. So right gaze palsy and with a right facial nerve. So I wanted to bring about the anatomical differences when somebody has a sixth and the seventh nerve. There are two regions where sixth and the seventh nerve go together. One is right at the nucleus in the pons. The nucleus of the sixth nerve is situated in the dorsal pons. So right at the nucleus, sixth and seventh nerve are together. Seventh nerve actually forms a loop around the nucleus of the sixth nerve called facial colliculus. So when there is a nuclear lesion of the sixth nerve in the pons, you'll have a gaze palsy because the sixth nerve nucleus is very close to a nucleus called PPRF, parapontine reticular formation. So these two together control the gaze to the same side. So this patient had a right pontine lesion of the dorsal side affecting the sixth nerve nucleus, and that's the reason why he could not look to the right. There was a gaze palsy. And because the seventh nerve, which is in proximity, also got affected by the same lesion, patient also had a seventh nerve palsy. However, once the both nerves, the sixth and the seventh nerve, come out from the pons, they still continue together in a cavity called CP angle, cerebellopontine angle. So once they have come out of the pons, then the sixth nerve is now a nerve. The nucleus is the gaze center, but sixth nerve only controls the abduction. So here, this patient had a left CP angle problem, and that's the reason why patient only had an abduction limitation with a facial nerve on the same side. The nystagmus can be because of cerebellar involvement. So that's the sixth nerve. Starts from the pons, goes in the CP angle. All right. Here there's a seventh and eighth now, and this is the sixth now. You can see all seventh, eighth now, and this is a CP angle. So this is cerebellum, this is pons, this is medulla. So sixth now in a CP angle goes with the seventh now, and a patient in a sixth nerve palsy can have a concomitant seventh nerve when it's near the brainstem, either pons or CP angle. If it's pontine lesion, likely to have a gaze palsy. If it's a CP angle, likely to have a nystagmus in the other eye. Now, the sixth nerve continues from the pons, goes through and what make your case of a block in for a sphenopalatine ganglion. So it continues through the pitreous bone in the cavity and then enters the cavernous sinus and the orbit. So here it is very close to the apex of the pitreous bone. And it can either get affected if it touches the pitreous bone, or there can be diffusion of the anesthetic agent when it's given here. Basically, it's too far for a direct injury. So it can be that the anesthetic agent diffuses, leading to sixth nerve nucleus. So that's about, we saw two videos of sixth nerve. Let's see one more video of again a sixth nerve palsy. This patient actually was told that you only have a diabetes and your vision, your problem will go away once the diabetes is controlled. See what happens now. Look at the left eye. Let me show you from the beginning. This is patient trying to look to the left. Looking to the left. Now looking to the right. You can see abduction is fine, but look at the left eye carefully. Looking to the left. Now looking to the right. Look up, patient looking up. and patient looking down. Right? We can look at the video once again. Looking to the left, to the right, looking up, and down. What do you see here? What all did you see? See, very clear, no abduction. Patient is trying to look to the left. There is no abduction. Right? Abduction is by sixth nerve. Right? So we're talking about the sixth nerve. We said that pons and CP angle, what happens? Now, look at this. No adduction as well. Partial adduction. Okay, and see what happens when the patient looks up. Elevation, no elevation. So elevation, adduction, which nerve?
Oculomotor nerve.
Third nerve, exactly. So you have a sixth nerve and maybe a partial third nerve.
No.
So now sixth nerve, as we said, pons, fascicle, vitreous, now it has come closer. And that's where the sixth and the third nerve come to close together. There are two areas where sixth and third nerve come close together. Not in the brainstem, because in the brainstem, third nerve is in the midbrain, sixth nerve is in the pons. So this can be either cavernous sinus or this can be orbit. Which one nerve would determine whether it's cavernous sinus or orbit?
Optic.
Sorry?
Optic nerve.
Exactly. If patient also has an optic nerve dysfunction, it's an orbital lesion. Cavernous sinus is behind, optic nerve is not really very close to the cavernous sinus. So if the optic nerve functions are normal, then this is likely to be a cavernous sinus lesion. So we're now talking about optic nerve versus cavernous sinus. Look at this patient. You can see there is a ptosis here, clear ptosis, patient looking to the left, no adduction. Here it looks like as if abduction is normal, no depression, no elevation. So which nerve is this? No adduction, no elevation, no depression. Third nerve with a ptosis, right? Now let's see fourth nerve. Fourth nerve in this situation, you have to look at the intorsion. Because third, fourth, and sixth nerve can be together in the orbit or cavernous sinus again. And see, there is no intorsion. So fourth nerve is not functioning as well. And look at the sixth nerve. Now see, the abduction also is not full. So third, fourth, and sixth, if the optic nerve was not, then orbit, but optic nerve was normal here. So this was cavernous sinus. Patient had a cavernous sinus lesion. Versus here, when the optic nerve also was affected, and you can clearly see there is a clear ptosis, complete ptosis, not going, no abduction, no elevation, no depression, no adduction. So this was an orbital lesion. So in other words, sixth and seventh nerve, pons and CP angle. Sixth and third and fourth nerve, it can be cavernous sinus or it can be orbit. Optic nerve functioning, orbit. Optic nerve not functioning, cavernous sinus. So that's about the sixth nerve and its course through the from the brain to the eye. So orbital apex syndrome. So the other one more reason, anatomical basis of differentiation between orbital apex syndrome, superior orbital fissure syndrome, and the cavernous sinus syndrome is this V1. Apart from optic nerve, the first branch of the trigeminal nerve would be affected in the orbital apex, while in the cavernous sinus, it will be V1 and V2 both. Okay? And that I'll show you the picture of how V1 and V2 are anatomically located. We'll continue one more six now. What do you see here?
Yes.
Bilateral disc edema. Yeah, but bilateral disc edema. So patient had a papilledema. So how a cranial nerve is associated with papilledema, raised intracranial pressure. Patient had a little limitation of abduction. However, this is what you can see in patients who have raised intracranial pressure. Patient looking to the right. You see abduction limitation here. Looking to the left, abduction limitation here. So bilateral sixth nerve palsy can be seen in raised intracranial pressure. Do you know what is it called? Sixth nerve palsy seen in raised ICP in papilledema. It's called false localizing sign. And false localizing sign is again seen because of the anatomical basis. Sixth nerve has a very long course from the pons to the eye, and it is a precarious course, especially as I said, at the apex of the petrous temporal bone is where it's very close to the bone. So if there is a pressure, the nerve gets hinged against the bone, causing a nerve palsy. So while there is no tumor there, you have a nerve palsy. That's why it's called false localizing sign. And the anatomical basis is because of the precarious course of the sixth nerve in Dolores Canal. It's called Dolores Canal and in the petrous area. And that's the area why even your sphenopalatine block would come into view. So that's about the sixth nerve. From the pons to the eye, third, fourth, seventh, and eighth nerve, they're all together. Now, this is just a picture of how severe these disease process can be. And another important anatomical proximity of these cranial nerve is the sinuses. And this is the patient who had, it started with proptosis and all the other cranial nerves, but ultimately it turned out to be mucormycosis because of the proximity of the sinuses. In fact, within 12 hours, patient passed away. Now, orbital apex is formed by these, and this is the diagrammatic recognition. In the interest of time, let me rush to the orbital apex syndrome. We mentioned it. This is the anatomical feature that I wanted to show you. There you can see clearly that V1 and V2. This is V1, this is third, this is superior orbital fissure, and cavernous sinus is somewhere here. And you can clearly see that V2 is away from the superior orbital fissure, while V1, sixth nerve, third nerve, fourth nerve, they are all. And this is optic canal. This is optic canal. This superior orbital fissure where V1 goes through. Okay, and cavernous sinus you find here. I mean, this is a famous diagram of a cavernous sinus where you find that the V1, V2, everything is with the cavernous sinus. This is the distribution of the sensation which goes into, and this is the orbital disease which can be caused by some of the other orbital inflammatory disease. Now I'll end with this case where you have a patient with a double vision with a lid droop in the left eye, which was little worse in the afternoon. Patient had a moderate ptosis of the left side, and the ocular motility showed total third nerve palsy, like here. Okay, and patient had diabetes, had hypertension, and pupil was normal. So now we're talking about third nerve. Pupil was normal. So we say, oh, this is third nerve palsy, 67-year-old female, diabetes and blood pressure. This probably can be ischemic third nerve palsy. So the question is, do we do MRI? Theoretically, MRI may not be required because you said this is an ischemic third nerve palsy and pupil was not involved. However, one thing which was going in favor of doing MRI is that this was not a complete ptosis. However, this patient did not undergo MRI. It was she was given only some vitamins. However, 3 days later, she came back with headache, and now the third nerve progressed, and the pupil also became bigger. And when the MRI was done, patient was actually found to have a very large aneurysm. So in a third nerve palsy, anatomical basis, it starts, the nucleus is in the third brain, in the midbrain. Please read about the anatomical features of the nucleus because there are various nuclei of the third nerve throughout the midbrain. And from the midbrain, the third nerve starts fascicle and it reaches the orbit. Through cavernous sinus, it reaches the orbit. Now, when it comes out of the midbrain, there are several arteries which cross the oculomotor nerve. The artery of importance for us is posterior communicating artery because it's very close to the third nerve at the midbrain. And if there's an aneurysm of the posterior communicating artery, it can impinge on the oculomotor nerve, causing a third nerve palsy. However, in the third nerve, the pupillomotor fibers are on the surface, while the blood supply starts from the center and goes out. So if there is a surface lesion, there is a very high likelihood that the pupil will also become large in a third nerve palsy right in the beginning of the disease. However, as this case shows you, that sometimes pupil may not be involved. However, it is still a aneurysmal palsy of the third nerve. So in a third nerve, what is the most important point to note? One, you need to remember that it starts from the midbrain. And second important anatomical feature is that the pupillomotor fiber is right on the surface. So the compressive lesion of the third nerve is likely to press the pupillomotor fiber, causing anisocoria or larger pupil on the optic. So I'll end here. Megha, if there are any questions, I'll be happy to take. I have not covered the theoretical details of these nerves because there's nothing that we need to discuss there. Unfortunately, you would have to read and remember, but hopefully some of these correlations with the clinical factor would help you to remember those details which you need to know. Yes.
I completely agree with the thought that these practical aspects which are going to help all postgraduates put together all the theoretical points. And thank you so much for bringing them together in such a concise manner. We'll just take a couple of questions, sir. Like the last case of yours emphasized, in a third cranial nerve palsy, the anatomical red flag signs where a normal pupil would still need an urgent MRA, an MR angiogram. So if we could just enlist them, sir.
No, so first, let's look at it from the theoretical point of view, and then I'll tell you what is the clinical deviation. In the theory, because that's what we need to know right now, is only scenario where the urgent MRI with MR angiography is not required is where patient has a complete third nerve palsy, point number one. When patient is above the age of 45, patient has a vasculopathic risk factors, and patient's pupil is normal, and all other cranial nerves are normal, and there are no other neurological signs and symptoms. So a complete third nerve palsy with normal pupil in an elderly person with a vasculopathic risk factors and no other neurological signs and symptoms like headache, we can observe these patients. However, as my case highlighted, we should still call the patient back after 1 week, because sometimes the pupil can be involved a little later in the disease. Around 15% of the patients who have a compressive lesion of the third nerve can still have a pupil being normal initially, and people can get involved a little later in the disease. So it's important that we call these patients back again. Now, this is theory. Everybody else, incomplete third nerve palsy, younger patient, younger than 45, involvement of the pupil, aberrant regeneration of the pupil, patient having other cranial nerve apart from third nerve, so concomitant other nerve palsies, or having a neurological problem like headache, should have urgent neuroimaging, and the urgent neuroimaging of choice would be MRI with MRA. Now, more and more case reports are coming out where even if the pupil is normal, and even if in a older patient, they can still have aneurysm or other sinister problems compressing on the third nerve. So practically, almost everybody now would request for neuroimaging in everybody who presents third nerve palsy. But that's the clinical aspect of it.
Okay. So how long does it take for disc edema or papilledema to set in following raised ICP or an inciting event? Is there a period of duration after which we can assume this might be visible?
No. So we have to discuss and imagine papilledema like glaucoma. right? As there are different causes of raised intraocular pressure, and there is no fixed timeline or guidance to say that pressure would come down or would come down only with one medication. Similarly, intracranial pressure depends upon a lot of different factors. And similarly, the resolution of the disc edema and raised ICP also depends upon those variables. So there is no fixed limit. However, if the raised ICP, let's say you started the medication, so this question can be reframed in a way which says that how do you know that your treatment is functioning and the disc edema is going down? Please remember, the disc edema will go down either because your treatment is functioning, or disc edema will go down because the axons are dying. The dead axon, they turn into glial tissue, they cannot swell. And every insult which is not treated, within 4 to 6 weeks, they start converting into optic atrophy. So how do you know whether the disc edema which is going down is because of your treatment or is because of the non-functioning treatment? And that we can take help of OCT, where you can use RNFL and GCC and see whether RNFL is reducing and GCC is stable, your treatment is functioning. RNFL is going down, GCC is going down, your treatment is not working, you need to increase the dosage. But there is no clear timeline for the resolution of the optic disc edema. Majority of the cases, you will find that once the treatment is instituted, within 4 to 6 weeks, the disc edema on the optic nerve or the photograph, you'll find that it's resolved.
Okay, fine. That's really helpful, sir. With this, sir, in the interest of time, I'd like to end today's session. Just another announcement for all our viewers. Our next class would be on anatomy of the exotic muscles by Dr. Ramesh Kekunya on 25th of March. And it brings me immense pleasure to announce physical iFocus, which would be held in Hyderabad from July 5 to July 12th. And the registrations are now open. Please find the QR code in your inbox. Thank you so much for joining us, sir. This was a rather enlightening class, and it has taken us back to our basics quite literally. Thank you, sir.
Right. Thank you so much.
A very good night. Thank you.